Being recorded.
All right, 10:08, and I'll go ahead and call this special board meeting to order. Board members present, Ken is here, Sherry's here, Shelley is here, I'm here, and Rich should be joining us hopefully momentarily. Let's go ahead and rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. All right, do I have any requests for modifications or deletions from the agenda? All right, if not, then may I please have a motion to approve the agenda?
I move it, or I second.
Okay, I'll move.
Move
You
second, thank you. Okay, all in favor, Shelley?
Aye.
Sherry?
Aye.
Ken?
Aye.
And I'll vote aye. And we will be meeting in closed session today pursuant to Health and Safety Code 32106, reports involving trade secrets. And that brings us to the public comment period. As a reminder, for folks who want to make public comment, comments are limited to 3 minutes, and this is for items not on the agenda. I don't believe we had any submitted prior to the meeting. Is there any comment online or otherwise in the room? Okay, then we will go ahead and move on. Item number 9, approval of the special board meeting minutes. These are the minutes for our meeting from September 26th. Do I have any questions, comments, feedback from board members? No? Okay, do I have a motion to approve? Thank you, Shelley. Do I have a second?
I'll second.
Thank you, Ken. All in favor? Ken?
Aye.
Sherry?
Aye.
Shelley?
Aye.
And I'll vote aye. And that moves us into SHD fiscal year ending 6/30/24 operating budget. Steve? I think we want to bring up the presentation, please.
Didn't send them the PowerPoint, but this looks like the PDF. This looks readable. You all have it in front of you as well. Here we go. Okay,
Thank you.
all right. So back on October 12th, we met as a finance committee, and a version of the fiscal year 23-24 budget was provided to the finance committee for their review and comments. And based upon that meeting, went back and refined the budget that was provided to the finance committee and have prepared a final, if you will, final draft for your review and approval. For the benefit of Sherry and Shelley, I don't want to go through, I'll talk about this as much as you all want. This is your meeting. But I'm going to go through some of the information rather quickly. Please stop me if you want to talk about any of it in detail, and then I'll just dive into the budget that's before us. So Sarah, just sit tight for a minute. So for the first, good, great. Thank you. For the first seven pages and 13 slides, what I've done since I've been here is I present historical components of our income statement. So information about revenue, net revenue, other revenue, then go into expenses, operating revenue, then the non-operating elements, and most significantly is how our supplemental payment programs work. Our supplemental payment programs, as we've discussed in some depth and regard, is where the Seneca Healthcare District, a public entity, makes what's called an intergovernmental transfer to the state of California Department of Health Care Services, and those funds are taken, spent, and then we receive a federal match on those funds, and then that federal match on our intergovernmental transfer is returned to us in the form of a supplemental payment. The tricky thing, let me back up. There's 3 programs that work under a supplemental payment intergovernmental transfer environment. 2 of them are related to patient revenue. 2 of them are managed Medi-Cal enhanced or supplemental payments. The other one is through a quality grant, originally the Prime grant, and now the QIP, the Quality Incentive Pool program. So same idea there, that we put up an intergovernmental transfer, those funds are federally matched, and then we receive a supplemental payment back. The whole uniqueness of it is, or the whole specificity of it is that the Hospital Quality Assessment Fee Program, HQAF, and the rate range are Medi-Cal managed care payment enhancements. And they, for financial reporting purposes, per the auditors, for generally accepted accounting principles, get put into a offset to our adjustments to revenue. So when Medi-Cal pays us, say we generate $1,000 worth of charges, and Medi-Cal pays us $100, which is sadly enough representative of how they pay us in the emergency department. Other areas, they pay a little higher percentage. So when we get that $100 bill or $1,000 bill comes out, we get a $100 payment. We record $900. The claim is fully settled when we get the $100 payment. So we have a $900, what we call contractual adjustment to revenue. So on our financials, we record $1,000 in gross charges, a minus contractual of $900, net revenue of $100. So when we get these rate range and HQAF payments, ultimately, when we report our financials for audit purposes, they're in conformity with generally accepted accounting principles and all that, it gets moved up into the offset to contractual adjustments. It severely, in my mind anyway, and it severely misstates our operations. For one, it's a lump sum payment at one time, and it doesn't truly reflect how we're getting paid on a claims level basis and our day-to-day operations. And this will become more significant when we get to the end of the budget and we talk about cash flow. So during the interim period, what I will do is I will record the supplemental payments below the line, down in the non-operating revenue. So I allow our true operations to be reflected on a regular basis. The other thing is that the timing of receiving these supplemental payments is variable. I guess that's a fairer way to say it. And so if we budget it for 1 month and we don't get it, we'd have this horrific budget variance, and then we're just saying, well, we didn't get our payment or whatever it is. Whereas we can manage our accounts receivable and our revenue cycle so much more effectively if we present our financial statements on a claims basis kind of thing. So I guess I'm going through this long-winded explanation because the budget is presented in this manner, where we go through our operations, we show our non-operating, our true non-operating revenue, which is our tax revenues, our donations, our interest income, investment income, and those things. And then we work our way down to the supplemental payment, and then ultimately work our way down to the supplemental payment less the IGT, because the financial accounting allows us to only show, or requires or mandates us to only show the supplemental payment in the income statement. The intergovernmental transfer is, accounting things here, is like an equity contribution. It doesn't impact our operations, but it sure as heck impacts our cash. So it's the way that I do it is I just work it all the way down to the bottom, that when we do a budget, we want to have at least a break-even budget after the intergovernmental transfer. If we don't, and break-even means 0. And if we have a negative after the intergovernmental transfer, that's showing that we're budgeting for a cash loss. And we just don't do that. We can't do that.
I have a question. So we go live with the partnership contract in January of '24, correct?
Mhm.
So the QIP monies are based on quality. So, and aren't they in the rears? I know where I
Yeah, a
came
little
from,
bit.
they used to be 18 months in the rears. So how do you, is 6 months for the
6.
partnership contract?
We don't know.
Yeah, so I'm just wondering how we can project revenue, non-operating or the supplemental payment revenue based on monies from a new contract when the QIP monies are quality. I mean, I assume we have a target for quality metrics. And in the contract, we've identified the different quality incentive levels for, for money, for revenue. How do we project that? And then how is it accounted for in the budget?
Okay, a couple things. One is that,
I know I'm new to this, so.
no,
At least
yeah,
for the critical access
Good question.
hospital.
Good question.
fabulous question, actually. So, the first thing is that, yes, the QI program does run in arrears because it has to be, the only way, it can only run in arrears because we have to go back and we have to look at metrics for a certain period and then the payments made. So even when we go into 2024, we're gonna be dealing with metrics from our time with California Health and Wellness and Anthem.
Okay.
The other thing that where they made it, I don't know what the right word is, probably easier, is that small hospitals like Seneca, if there was a true distribution of the pool, we probably would have taken, would have taken a hit. Our benefit under the program would have been less than it was historically. Under Prime, we received a net benefit of $750,000. We put up 750, received $1.5 million. And that was just a pure grant program. We did these activities. Now under QIP, there literally are metrics that we have to meet. And you're able to select a minimum, and I think it's like 3. And so we were able to select the minimum. If we selected the minimum and it was a true distributive formula, we would have received less. So when they wrote the plan, I can't remember what they call it, the state plan that went to CMS, they built in a basement or a basement benefit for small hospitals like ourselves, Surprise Valley, probably Alturas, those types of facilities. And so if we meet our metrics, we're guaranteed this net benefit of $750,000. What threw us in the first year of it was we were expecting to have to do the old way of doing 750 IGT and $1.5 million supplemental payment coming back. But it ended up being where we only had to put up an IGT of like $300,000 and that we received like $1.2 million. And actually our benefit in year 1 was over $800,000, just the way that the whole program worked. So we're fine for 23, 24. Going beyond that, I honestly can't tell you what that's gonna look like with partnership. The program should not change because it's just who's distributing the payments and whose data we're using. So I don't anticipate
Okay,
any change.
okay. What
Other
is,
than partnership seems to the incentives for QI, for quality, seems to be more of a focus for them. They're very focused on
oh,
quality.
yes. Oh, yeah.
So
There may be more QI measures
that they
added than what we're currently following.
Right,
That's what we're anticipating,
right.
all population health, preventative care type measures. We're trying to figure out how to get Cerner to work for us
Right,
when it comes to this.
right. Yeah, they have a lot of pop health.
I'm curious what the 3 metrics are
That we're tracking currently.
that we're tracking.
it is
Currently, we're doing depression screening and colorectal screening. I don't know if the third one.
That's the only one I knew was the
I just am curious as examples. So
I think they have the A1, for us it was the A1C.
you can select from
I
a
think, yeah.
the list, and we choose the ones that are most capable of pulling these data.
Yeah, the funny thing is, it's not funny at all, actually, that during our last clinic survey in, that was 2021 perhaps, we were cited for not doing enough lipid panels. I don't know if I've talked about that in this meeting before. And recently, our compliance officer received a notification that they're withholding all of our payments on lipid panels because they think that we're over ordering them. So now we're
Not
undergoing
enough,
this audit, they're trying to figure out why we're ordering so many lipid panels and so I gave her a copy of our citation last time so she could give it to them to say, you cited us for not doing lipid panel screening. So we did all the education with our providers and they started doing lipid panel screening and now they're withholding our payments for lipid panels. So it's really insane. So I really hope that that's not the type of thing we're gonna start getting into with partnerships.
Yeah.
That we're cautionary, I would say.
Okay.
Yeah.
And what is our Medi-Cal payer mix?
22%.
22%. I thought it was big.
22%.
It's a little less than that, maybe closer to 15, but that ballpark, yeah.
I knew it was a lot of money, put into a lot of money. Okay. All right, thank you.
Yeah, and we're kind of made whole on Medi-Cal through these programs. So you don't want to jinx it, but it's with the supplemental payments, we do okay on Medi-Cal. And we do okay on Medicare, and then our commercial was really good, so.
But our main goal eventually would be to have an operating, not have an operating loss at all,
Correct.
right? Yeah,
Yeah,
that's
it's
where we
where-
would want to get.
Our revenue from operations and our expense from operations are at least net zero to
Yeah.
a small EBITDA.
But
small
ideally, our IDT money, we would be able to then use for
capital
capital
cash on
improvements.
hand.
Yeah, exactly.
Yeah, that one slide where it's
And we
the
kinda-
negative 38.27%, that was a little, I wasn't at the financial
There's-
meeting, that was a
yeah,
little
there's-
alarming.
Well, there's been a lot of investments.
Yeah,
Yeah.
yeah, because we've had a lot of investment in our new facility that we've done over the last year. So I think that's where most of that difference came from, right?
Yeah, the big thing, and you can see it,
We're looking at slide 9 right now.
yeah, why don't you go to, slide 9, probably like 24.
There it is, right there.
There.
Nope,
Yeah,
no more,
yeah.
sorry.
Well, it's kind of both, so just kind of straddle that 4 and 5 page there, Sarah, so we can see that, yeah, perfect. So, yeah, that was the loss we had now. Couple of things went on, a couple of things that were present there is that, if we went back and, don't do it. If we went back and we looked at the trend on revenue, and this is something we talked about in the finance committee, that our revenue, if you go back to 2018, 19, 26 million, 28 million, then COVID hit in fiscal 6/30/20, well, at least 3 months of it. And then our revenue took a hit and it's slowly climbing back. So, but in those fiscal 20, 21 and 25, when we had the impact of COVID, we were receiving more supplemental payments. We received a PPP loan from the federal government for $1.5 million. It was a loan program that was made available that for businesses that were impacted, smaller businesses. I think it was under 500 employees that were impacted by COVID. And then the myriad of COVID provider relief fund programs that we received over the whole period. We've received over $5 million in supplemental payments. And we actually have about 1.7 million, maybe $1.8 million hanging out there for fiscal 23 which is a combination of two things that are the final settlement of all of our provider relief funds. They came in different phases, phase 1, phase 2, phase 3, phase 4. Phase 4, we just submitted the report by September 30th. And so that's gonna clear the books, and we'll recognize about, like I said, about $1.8 million. So that $5.8 million loss is gonna be reduced dramatically. And then really the variance there is gonna be the expenditure commitment we made in fiscal 23, mainly for Cerner and other things around the facility. So the problem with that provider relief fund is they give you the money and then you have an extended period of time to use it or offset the impact of COVID. And so we have the money in the bank, and then when we do something like we're gonna do here, it's just a paper income, you know? So we already had the money, we've been sitting on the money, now it's just recognizing the income. Because we have to defer the recognition until we know we've really earned it. So that was just a fun accounting
So Steve,
exercise.
that recognition is gonna be coming in our fiscal year 23 or the next?
23, it'll be, see, here's how it worked, is that fiscal 23 was when we had what they call the reporting period. So we had until June 30, 2023 to expend COVID funds, which we did in multiple ways. The big thing is that we're using the disposable curtains in the hospital. And if you guys have gone to the bathroom here, the touch-free soap, touch-free faucets, we've done all those things. If you guys remember, we had the COVID hut outside the ED, which was a huge thing to have. And we had to have power, so we had to rent a generator, you know, on and on and on. So we had through June 30 to do those expenses. The other thing is that we're also able to claim lost revenue during the COVID. So we waited through June 30, and then we don't know where we stand until we submit the reporting, which was September 30. So now I can submit the report that I sent in for this phase 4, give it to the auditor. He's gonna say, yep, you know, we filed and said we've used all the funds, and then we'll just do an entry to bring it in. So we'll be done with it, yay, and we move on. Okay, so those are the big takeaways. Is actually, Sarah, if you would just real fast go to page 2, and then the board can see what specifically I'm talking, or slide 2. So we begin page 1. Yeah, that's it right there. Okay, so again, the reference is June 30th, 2018, 26 million, June 30th of 19, 28 million, then boom. And it's not just COVID, as if you've looked at the clinic statistics that we provided based on visits, we can see the decline of the clinic visits, and the clinic is the hub of our healthcare delivery and of our patient revenue. So we've gone from that level to the 22, 21, 23, and now we're just climbing back.
Steve, just help me understand here. So we had COVID, and then we had loss sustained through 21 and 22. How much of that is impacted by provider shortages? Do we know?
Yeah, if you guys don't mind, why don't we, Sarah, let's go to, I know we bounce around a little bit here, but let's go to page 12. Here we go. Blow that up a little bit.
Definitely need reading glasses for that one.
Yeah.
Is that? That's really, oh, there we go.
There we go.
Okay,
Thank you.
so, yeah. So these are just clinic visits. I don't have all the stats back there, but I think this tells the story pretty clearly. So if we go back to 2018, we had 11,146 clinic visits. 2019, 11,490, and I'm just reading what you're looking at, so you can do this, follow along. And then you can just see the decline. And then Sarah, if you would just scroll down to the next box, to where it was 7,200 in 2022, and then here's budget and actual 23, and then budget 24. Sarah, sorry, just hop up to the one above real fast. And I think, other than the numbers, I think the third row there says, well, third and fourth row say it all. So when we look at what would that be? That's 5 years. 5 full years. During those 5 full years, the only constant was Dr. Ware, Dr. Walls, and having a walk-in clinic, but the walk-in doesn't, Steve Haig's been here quite some time, but the other 2 areas, our other 2 provider offices, you can see, what we have there. From Mark Nielsen to Locum to Dr. Salehi to Dr. Cooper, Dr. Ward to Dr. Suarez, and then just, we've had mid-levels in there. So.
Thank you.
All right.
So there's only an increase of 6 visits for the 23-24 budget year for the walk-in clinic.
Can the slide, the box below, Sarah, please. Yeah, so what we're saying, Shelley, or what I'm saying, is that, and we talked about this yesterday actually in a meeting about clinic staffing and all, is that we're saying that we want to drive the demand, or as Sean says, the repatriation of business through the scheduled clinic offices. So for Heather Smith and the locums provider right now, Dr. Russo, and then we'll just presume that there's always going to be a demand for walk-in, mainly summer, but still there's people that use the walk-in. I personally use Steve Aiden as my primary care provider, so there's got to be other people like me. So, but maybe that'll change a little bit. But yeah, we just assume that there's going to be a demand for healthcare at that level.
The point being that we want more prediction capability, and scheduled visits are more predictable. So when you start getting into your averages and you're predictable, the walk-in's the walk-in. It could go up, it could go down. I suspect that as we start to bring people into a primary care provider out of the walk-in, if somebody wants to choose a primary care provider and actually establish, then you may see a drop in the walk-in clinic, but you'll see a rise in the other scheduled offices. That's what I'm looking for, predictability. I want to be able to say, every provider that we have in the clinic that's accepting that is a scheduled patient, is doing X per day on average. Then we can create predictability within the clinic, and that's really what's important, and then grow from there. Saying, okay, we want 10 a day, now we want 12 a day, and being able to get that going. That's really important. The growth in the clinic is the key economic engine of this entire project.
Right. Well, that just stood out to me because I know we've had several days when we haven't had a provider in the walk-in clinic.
Well, we have a round robin now. Every provider that comes in now is expected to pick up the walk-in when we do not have a provider, so we won't have to shut it down. Every conversation now with a provider that comes on is, if we do not have the walk-in, there will be a round robin. So when people come in there, we will be partitioning it out. That wasn't always the case. When it was down, it was down.
Right.
And now the new
How
discussion
many
is that
occasions now has that occurred on, have somebody pop in? Or what,
more than we want.
huh?
It's still not.
Still happens.
Where the,
No, I was just curious, I mean, how often is that happening and kind of,
How often do we not have a provider walk in?
Yeah.
More than in the past, but once again, the pressure valve and relief valve on that is that now we don't turn people away.
no,
I take them to
I get
ER.
that, and I'm seeing this as a positive thing, if it's actually happening, it's
Mhm.
being covered.
Yeah. I'll give you an
And,
example, there wasn't a provider last week, Friday. And,
And contractually, it's only held to 47 weeks, right?
right, so our primary care, Heather Smith picked up the walk-in.
so they're not having to go to the ER anymore?
Correct. We don't want them to go to the
Good.
ER. So that's the whole idea, is to create more flexibility in the clinic. That's, there's a lot of attention being paid on the clinic,
any uptick in the number of people coming into walk-in?
about average.
I guess historically, the clinic has been what has raised us in the black.
Yeah.
Not the hospital. I mean, usually the clinic is covering what we're doing over in the hospital, so we have the
Yeah,
hospital.
so if you want to know, we know this. The key to our success financially is increased volume repatriation into family practice, general medicine, right? Primary care.
And
So-
specialty care,
What's that?
and specialty care.
And specialty, and growth of specialty. So we're gonna keep the walk-in. We have more flexibility around Robin effect with our new providers. We do have another provider this weekend that we're interviewing, so we're hoping to get 4 actively accepting providers, where they're actively accepting, and then we have a very big, we have a meeting coming up, tomorrow? That is a very big marketing push out to repatriation. As long as we have providers, we can get people to establish.
And Dr. Greeley's starting
Dr.
soon,
Greeley started yesterday.
And he's how many days
He's
a
only
month?
4 days a month, but
Oh, that's
hey,
still,
it's
that's
it's
good.
another
Yeah.
choice.
Yeah.
That's
Somebody here.
So
So is he assigned a panel of patients, or how does that work?
he will establish, he'll establish.
We have waiting lists of patients. We're calling them and we're starting to fill out these documents basically.
Same with
Okay.
Heather Smith. And then Russo and whoever else we get, we'll start calling them.
I think that's huge.
And
That's a
then
huge.
we're going to add, once we get well established, depending on what happens with this provider, the next round of providers that we're looking at, we will add on to Cerner on the ER discharge instructions, or even the go home instructions from the hospital following an inpatient admission. If they're not established with the primary care, their instructions will list our current providers who are accepting new
Good.
patients.
That's nice.
And so that will be part of this push too.
Nice, nice.
So from all angles, trying to get people hooked up in here.
Maybe even a flyer during the flu clinic
Right.
thing, about listing our providers, maybe you
There's
already
gonna be
have
a
that.
whole push. We're sidetracking Steve on this thing, but I think that you picked out that the engine to Seneca is the clinic, and between COVID and Dixie and the current status of being able to get family practice physicians, it's struggled, getting doctors to come up here or even mid-levels has been a struggle for us. Once we have them here, we can establish people.
Yeah.
We have people looking.
So the current physicians are current Dr. Ware and, I guess Dr. Greeley.
Heather Smith and Dr. Russo.
Yeah, are they, did you meet with them and discuss the expected increase in their panel of patients and?
I mean, the expectation. I set the expectation in the very first meeting with all of them. Now, have we pushed people into their practice? Not yet. That's what we're about to do.
Okay.
So
But
Sean,
the
talk about how many patients per day this we're really asking.
Well, on an 8-hour day, I want to see 12, which allows them one every 30 minutes and 20% in 2 hours of administrative time, so they get their charting done. In a 10-hour day, I want 16. If we do 12 on an 8-hour day, we're doing 8, and we do 16 on a 10-hour day, we're going to see that 12,000 mark. If
Yeah,
we have
and that's
all
not, and that's
offices,
not huge
if
volume.
we have all offices working at that capacity,
And
we'll see
they're
that.
okay with that?
Most of the people we're interviewing are seeing at least 30 patients.
Yeah,
Right.
And
Exactly.
they don't
Sure.
like it, and they want to stop. They want
okay.
some breathing room, and so this is very appealing to them.
And our current physicians are okay with that?
Which current physicians?
Ones that are seeing 4 or 6 patients a day.
I just don't want those people to feel pushed out.
Mm.
It's important that they step up to the
Well-
plate.
Well, Dr. Ware has a closed practice.
Okay.
So we're not pushing anything to her, we just want her to see the patients she's already has.
But is she gonna participate in the round robin?
She does.
She does.
She does,
She
okay.
does.
Thank you.
She's been really.
It's been very good that way.
Okay, good.
All right, Steve, sorry. This economic engine.
So, just because that wasn't enough discussion, I have a couple more comments about this that I want to make clear to you. So, clear to the board. In this budget, we are projecting an increase in revenue. We have to. We just can't continue to operate at the level we did in 2023. No, it's not sustainable, short term or long term. And so what's reflected here is one of the areas where we are showing a increase over 2022-23. But I think what the key takeaway here is, just like we were talking about, you know, do you consider the impact of not having someone in the walk-in? I'm not going to budget for things we can't reasonably predict. What I will budget for is that the walk-in provider is contracted to 47 weeks a year, and based upon that, we're going to estimate the volume. And we're going to presume that we have coverage for that individual when they're not there. Where we have challenges is when the absence of the provider is not anticipated, and we may or may not have coverage. We're putting things in place to have that. So I budgeted for the walk-in at a minimum to be staffed, 47 days, 8 hours a day, 47 days, 47 weeks, 5 days a week, 8 hours a day. So the other part of this is that as we look at an increase, you can see there's the open office right now. And we saw 133 patients. It's just the way we classified things. Somebody was in that office for whatever period of time. But again, we're budgeting zero with this budget. That's not our marketing push. Marketing push is to have another provider in there. So with that said, we're not budgeting for something we don't have in place. We have Dr. Ware in place in her current status. We have Heather Smith taking over for Dr. Walls. We have the locum physician office, which is currently Dr. Russo. And then we have the walk-in. So when we look at Dr. Ware, I think we had a pretty clear discussion that her practice is what it is, and that's fine. Heather Smith seeing 1,800 patients a year at 47 weeks, what I just outlined, she's under the same program as the walk-in clinic. That's not even 8 patients a day. That's 7.66. So that's not an exceptionally high bar.
She's currently tracking at 8.8 without the push. So current tracking is 8.8.
The
We
locum,
expect it to be 10 to 12.
the locum, the 2160 is just over 9. The reason I bring
In there?
Yep.
And he's tracking at 13.
So the reason I bring that up is to Shelley's point about, are we predicting that the walk-in clinic, is it okay at 2160? That's 9 patients a day. So that if the other physicians have what we would call capacity, they have the ability to see more patients, we'd like that to be new patients. But they have the capacity to assume additional patients, and if it cannibalizes or however you look at it on the walk-in, it still gets us to this budget number. If it's repatriation, new patients, then we start to get exceeding budget, improvement upon budget. So I just want to be really clear that this isn't, as we say, a pie in the sky prediction.
Bar is set pretty low for volumes for this budget.
And we have the providers in place right now, so you never know.
Yeah.
Never know what happens. So So that's that.
And there's no increase in specialty, though,
You know what, I talked about this at the finance committee meeting. We are anticipating and we are seeing an increase in specialty so far this year with Dr. Jensen seeing more patients, doing 2 days of clinic, and Dr. Watson having a pretty consistent, he's our orthopedic surgeon that comes up for 1 day of clinic and
He
a
actually
day
wants to go 2
of
days.
procedures. We're seeing a good production for him. So theoretically, I should have increased that number. So
Yeah, because if he's gonna do a second day.
yeah, it is. I think where it's more reflected, yeah, it's gonna contribute a little bit in the clinic revenue, but we've reflected the impact of that in the OR, the surgery.
Oh.
Number of cases there, we reflected an increase. So we didn't necessarily reflect the impact on diagnostic services, but so that's that.
Okay.
Okay, I don't even know where to go from here. So,
Well,
Sarah?
I would ask maybe if, Sherry, do you have any questions?
No.
Okay. Go ahead, Steve.
So, Sarah, let's just go up real fast to page 8, slide 16. So I'll go through this quickly. I just wanted to bridge the gaps. So this was what was presented to the finance committee on October 12th. Sarah, you can go to the next page. Please. Can we get it to where we can fit both slides with it still being able to read it? I think that's a no. Just go down a little bit. I think we can probably squeeze it all in. Okay, that's perfect. So page 9, slides 17 and 18. Okay, so this top slide, here's the changes that I made to the finance committee budget. Net patient revenue, other operating revenue, no changes to those two items. The changes were all down below in operating expenses, and then a small change to investment income based upon the cash flow that we pulled together. But within the expenses, there was a decrease of $176,000 to salaries and wages, and then a small decrease of $3,000 for other operating expenses. So Sarah, why don't you go ahead and cursor down to that slide 18, sorry, blow it up a little bit. Okay, yeah, perfect. So when we prepared, or when I submitted the budget to the finance committee, Governor Newsom had still not signed Senate Bill 525. For those of you that don't know what Senate Bill 525 is, it was the proposal to specifically raise the minimum wage for healthcare workers across the board, not just hospitals. And we had a version of the bill that went to him, so we knew what we'd be looking at if it passed. You can hope, and not that I'm against a fair wage. I personally believe that it's a shame that people that are fully employed actually qualify for welfare benefits because they live in poverty. But this Senate Bill 525 was so draconian, if you will, in nature that it's hard for us to compare to such a big jump from one number to the next.
Well, it applies to all workers in the environment, not just people who are in the nursing profession, for example.
Yeah, that's absolutely correct and really true. And because what happens is when our minimum wage scales are our pay scales that are near the minimum wage, when they go up, they bump up against other pay scales, and we call it compaction. And so it has an impact throughout. So the cost is pretty significant. So between the finance committee meeting and this meeting, Governor Newsom did indeed sign the Senate Bill 525
On the last day.
on the last day. Go out with a bang. So the one thing is that, and this might have just been my oversight, but I could have sworn I saw that I'm just thinking the worst, that I thought the implementation date was January 1st.
Originally it was.
Okay.
Originally it was January.
Okay, I don't know when it moved, but the one that was signed into legislation was June 1st. And so that provided us certainly some relief for this budget. So I went back and recalibrated my projected increases for that SB 525 increase to only be for 1 month versus 6 months. So that provided that wage relief. There actually is a minimum wage increase January 1 to go to $16 an hour. The jump from 15.5 to $16 an hour is very close to the increase that came through our negotiation with the union. So everyone in the organization will be getting a 3% increase January 1, which is factored in there. But it also almost completely mitigates any impact of the minimum wage going to $6 for 5 months.
And going back to SB 525 for just a second, the final version that got signed gave us a little bit of relief for critical access hospitals in terms of our
Quite a bit
minimum
of,
wage
oh,
versus
heck,
everyone
sorry,
else.
yes,
Mhm.
a ton of relief.
It phased the pain over 5 years.
10.
And it
10,
was
yeah,
smaller,
that's right.
yeah.
Yeah, we started 18. The only thing to keep in mind is that the way that they wrote it, they gave great consideration, and this was through heavy lobbying through all of our advocates, that we start at $18 and then go up 3.5% or whatever the inflation rate is to get to ultimately to 25 in 10 years. That was the unaffiliated rural hospitals or unaffiliated safety net hospitals. And Susanville is a rural hospital, but they're part of Banner. So they will have to go to $21 on June 1st. So not only does that hit them, but then that puts us, we thought we'd be insulated from this competition issue a little bit, where they say, everyone's gonna run for the wage. Well, they're gonna be running to Chico. They're gonna be running to wherever, Reading, Red Bluff. So there could be a possibility that people could consider going to Susanville for the $21. We don't know yet, but we'll see.
Well, keep in mind the impact too. The next budget's going to be not only the 18, but it's also going to be our collective bargaining agreement. So it's not in lieu of, it's in addition to, which is really an impact to us, because it's going to be 6.5%. Collective bargaining up 3 year over year for 3 years plus the 3.5.
We still haven't resolved that.
Yeah.
It's not in, I don't know that it's in lieu of. I don't think
We don't, if we still don't have complete resolution on whether or not if we provide at least a 3% increase based upon this, whether or not then it would be on top of that.
something we do have to prepare for.
Yeah, so that would certainly be a consideration.
At least prepare for the ask.
Yeah.
Well, yeah,
Right.
I think everyone's wrestling with this very thought.
So if I may indulge you guys, I think though what this brings out is an opportunity for senior leadership and the board to recognize how well we treat our employees. There's only so much money to go around that we get that, but we're consistent. We've been, since I've been here, except for the worst of COVID, we've consistently provided for pay increases. Maybe they don't keep up with inflation. I don't know who's giving 8% increases, but
Kaiser.
that we're consistently giving pay increases. We have not done a single reduction in workforce since I've been here. Everyone kept their jobs through COVID. We supported the employees with their the disruption when the kids couldn't go to school. And just recently, we introduced the 3% 403B matching for our employees. You'll see that our employee benefits went up a little bit. So I think we've really created a very, and you guys with your support have created a very, very positive work environment. Our staffing is reasonable, and all you have to do is look at the labor unrest throughout the United States, both in healthcare and not healthcare, and how difficult it is for employers to demonstrate that they're being fair with their employees, and I don't think we have that issue, so.
Thank you for that, Steve.
Yeah, thank you guys. I did find a little error in the emergency department staffing. We had a position, or our budgeted staffing covered both by a contract registry and a employee position. The employee position was open, so I pulled that out. The employee benefits changed based upon the change in wages. I did find that we missed a surgery tech. We have a surgery tech through 11/30. I think this is another example of where we've taken an employee that's been here a while, and we've provided an opportunity for them to become a surgery tech, and we brought in a contract person to train them. And this is a financial commitment that we made to help the advancement, and it's good for us, of course, to have our in-house expertise, but provide this opportunity for an employee. So it's another great thing. The last piece is that when I did the cash flow, we are projecting a decrease in cash, which is summarized at the end. And so therefore, I think I brought down the interest income a little bit. So those were the changes, and then that led to slide 19, Sarah. Okay, so this is it. This is the budget that's before you. I didn't do the math on the, let me see if I can do the math real fast on the operating loss percentage. Sorry. Oh. So the operating loss will be 24.94. So, not what we want, but definitely something we can work with as a base. That this is the worst thing that happens. This is the way that our financial outcomes, we can live with this. So, and then we do produce a small 153,000, small in relation to the amount of revenue we generate. Bottom line, net income. The rest of the slides kind of break down the components of the budget. I don't know if there's any questions about that or anything you want to look at specifically.
Board members, anything you want to delve into more detail on?
You said that for 23-24, it'll be a 24%
24.94.
margin loss versus 38, so that's better.
Right, and so this is with a revenue increase, and I think we've talked about the sources of the revenue increase and that they are achievable and exceedable. If it's again, when we look at projecting, and this is what we did through the Wipfli study for the USDA loan, Wipfli has looked at us twice. Back in 19, where Shelley and Sherry, maybe Sherry remembers just from being around, but we're about ready to move forward with the new build back in 2019, or at least start the ball rolling. We're gonna do a market study and get things rolling, and then COVID just put the brakes. But we had a study completed by Wipfli where they looked at our market and they showed the capacity, the excess, or where, if you want to call it out migration or excess capacity, whatever it is, or, that there is a demand. There is a demand in our service area. And what we're performing at is below that demand. And so how we capture that demand is, we're gonna see as we go, but.
What were the recommendations? Was it to, build the outpatient clinic line, in terms of PCPs? Was it specialty services?
The biggest
What were the
recommendation that they had, other than, doctors, is they said that there's gonna be a demand for geriatric care in our community. They identified that our population was aging and it wasn't being replaced. Now, there's no, the newborn rate in our area is not high at all by anything. And so the population's aging out. So if you start looking at geriatric specialties, whether it's pure geriatric or the things that as we age, the needs that we have, whether it's cardiology or things like that, that there would be a demand for that, and that would focus, and that in turn said that there's going to be also a need for additional long-term care beds.
Yeah, just doing the math, just give you an idea of how attainable this really is, and the volume changes to the clinics. So with a provider doing 8 patients on average in an 8-hour day, which is ridiculously low, and a 10-hour day doing 10 patients, okay, with the current volume in the specialty, current volume in walk-in, we are going to, we'll hit 9,000 from, that's very conservative, 9,000. If we can take that to 10 patients in an 8-hour day, very doable. They're doing 30 everywhere else. 12 patients in a 10-hour day with the specialty the same and walk-in the same, we're looking at 11,500 visits. This is not too deep of a stretch. This really isn't. This is a couple of patients a day addition to the primary cares.
These are current providers.
Current. Well,
Yeah,
with
because we still
I
have
did
that
add a
office.
new one.
Right.
I did add a new one. I added an extra one. So with the current, obviously that's going to be a drop of 3,000, so still 9,000, with a higher level. But with another provider, 11,500, which is where we were back in 19 and 18, when we had 6 or 7 physicians. I think at the time, it's not too deep a stretch. This just isn't. We got to get there because 11,500 visits is going to change the calculus to this considerably. Right. It's revenue. It's all revenue. Knowing, here's the part that, knowing that costs to do business keep going up. They keep going up.
Yeah.
And we can't control those. And some of them are totally out of our control. So we've, it's imperative. The imperative is that we increase the volume in the clinic. Right. And then the peripheral stuff that happens from the increased volume, diagnostics and those types of things and surgical interventions and things like that will come. It's harder to calculate. Right. But utilization review, UR here is, we're about to jump off on a big education process for our physicians so they understand what we can do here and what to not send out. Don't send it out anywhere. We do it right here. Do it here. Right. Use our services.
Right. How far do we book out for like colons, EGDs and colons?
You can get a colonoscopy
Pretty quick.
It's on a list.
2 weeks.
2 weeks?
We were backed up and he increased the volume because he was on vacation, took some time. Okay. Then we caught up, but
now we're going through and making those callbacks, saying, hey, you're due, get you booked.
Because that's definitely a service that as the population ages, they're going to need to have more EGDs and colons.
Right. Well, and the colon screening reminders.
It helps us with our
people behind.
Right, right.
So can I ask a question about that with the study? So it basically said we have an aging population. Is our aging population, I'm assuming that's baby boomers, aging, yeah. Is it disproportionate in our area to other areas?
It's disproportionate. I don't know if they looked at Quincy or Portola or whatever, but yes, it's disproportionate to like national averages.
Okay.
Plymouth County is
Yeah.
disproportionate
Right.
as a countywide.
Steve, I think it might be helpful if you don't mind distributing that study out to all the boards, because
Okay.
we do have two new board
Yeah.
members.
And didn't they also talk about establishing a diabetes clinic type situation
Well,
in anticipation of the aging of the population
So-
increasingly?
but diabetes, chronic diabetes and things like that is something that can be handled at the family practice level. Endocrinology, where there's more of an issue, is something that we would like to bring up here. Dialysis is something that was mentioned.
I remember that.
And we actually did it just a, back of the napkin study, and it made absolutely no sense for us to build out, even though we had a potential donor to buy the equipment, the programmatic pieces behind diabetes, we wouldn't be able to manage. It's interventional radiology, it's special trained nurses. But my understanding is that Indian Health is still building that 8-bay or 6-bay dialysis
Dialysis.
center in Susanville.
I know they're still working on it.
So that would be great, because we can, at least then we can send somebody over for treatment and then manage them here from a diabetes perspective. But, yeah, things like that.
And home health. That
We need
is,
home health around here so bad.
I know,
Oh,
that's so huge.
I can't
Not to
believe
leave.
somebody in the community hasn't jumped into that one and made $1 million.
Well, traditionally, the physicians in the clinic would make home visits, seeing
That'd be
patients. I don't know if they currently still do, or if we even bill for that, but
I don't believe that they do.
I know they used
I
to.
mean, I think a couple of them would be interested. But Dr. Walls always made it part of his practice.
Right, yeah.
That's awesome.
Hospice, but other things, specialty stuff, derm, big one, podiatry, big one, cardiology, big one.
Yeah.
Those are the types of things that we need
Does
to
Quincy deliver babies? Do they have a hospital there that
They
delivers?
stopped.
They
No.
stopped.
They have an
stop.
aging
They're looking at a
population too
birthing
then.
center,
Yeah.
and with a midwife and stuff like that, but there's a lot of complication to it.
Mhm.
The outcry in the community was so great that they're looking for alternative birthing models. So,
They had to stop doing that about a year ago, is that right?
yeah, they've ceased for right now.
Yeah.
Mm.
I have no idea if it's gonna survive,
Mm.
if they can get it done.
Yeah, a lot of it really isn't about the population per se, it's really about the surgical teams and specialty care. The Specialists required 24/7 in order to operate, and boy, you talk about a financial drain.
Yeah.
So most of their staff were travelers, and so just double your
Right.
your
Yeah.
wages.
Yeah.
Yeah.
Good. Any other
Yeah.
questions? Do we want to talk about the slide 25, labor costs?
Legal costs?
Labor.
Oh.
I
We have to,
mean, I guess we already kind of covered it, but it's just kind of an interesting to point out the difference, the increase versus what our net bottom line
Mhm.
is, yeah. So,
So what this slide says is that for the proposed budget, there's a,
let me get my thing here if I do talk about percentages or whatever. Because it actually.
so 230,670 increase in salary. And this is what I was talking about here, the 148,640 increase in benefits over the prior year. The benefits typically run about 20%. So we are projecting that there's almost it's a 92,000 increase in our pension cost, and this is solely due to, one, we're gonna have a full year of the 403B matching, and that we've had more takers, more people participating. This is a great thing, where we will match the lower of 3% of their salary or their actual contribution that they make on their own. It's just a wonderful benefit. So, so that's why there's a little bit of disproportionateness, if you will, to the relation between benefits and salaries. That 230,670 represents a 2.69% increase in salaries. We here again talking about the things that I didn't even bring this up when I was talking about the benefits that we provide to our employees. We have two components to employee pay. There's this thing called a step increase, and what that is that each pay scale, each position has steps. I think there's A through H, and wherever someone falls on that step, and on an annual basis, an employee, if they're in good standing, not on probation or into some in advanced stage of progressive discipline, they will receive a 4% step increase. So then there's the 3% union negotiated increase. So some employees are receiving a 7% increase. So that's pretty damn close to inflation. So
Then there's SB 525.
But what's happened is, having only 8 steps and where the longevity of our employees, we're getting fewer and fewer employees that are eligible for step increases. So that's not as,
They're at the highest level.
that's not as
They just get the negotiated.
just get
they
the
just
quote,
get
yeah.
the union negotiated rate.
but that's an item that's built into our employee manual, that those step increases are there. That doesn't have to be negotiated.
Steve, you said only 8 steps. And in my mind, that seems like a lot of steps.
Well, we almost went to
In county
22.
land, it's usually like 5, isn't it? Something like
We almost went to 22.
And they're not every.
Not at 4%.
Not at
I was
4%.
gonna say, wait.
But think about it, Ken, and I appreciate your comment about the county, is that's 8 years. And that's assuming that you're hiring people in at step A, which is basically they have less than 1 year experience. And that's certainly not the case with the majority of our hires.
So a lot of them will come in somewhere around the middle or.
Or what we've experienced, in order to recruit hard to recruit positions, that we have to make a competitive offer that brings them in at a higher step. And so,
Right. Do you have a clinical ladder?
2 ladders for nursing.
I mean, we're trying to create an
Two different-
RN1, RN2. So the RN2, with an example, would be like an ER, experienced ER nurse who has multiple certifications. But it's not fully developed yet.
Okay.
It's a matter of, yes, it really is a matter of initial incentivizing initially to be able to come in at a competitive rate. And then where's the growth? What, do they allow them a growth ladder?
Mhm.
So if they go out and get additional,
Mhm.
certifications and licensures,
Mhm.
what does that mean to them?
Mhm.
That's the only way to stay competitive.
Right.
because of the bullet number 2 there, our average hourly wage went up 3.75% from 40.28. This is everybody. 41.8. We are going to have a net decrease in FTEs, and I could spend a lot of time telling you exactly how that happened, but I mean, there's pluses and minuses. There's the impact of Cerner, the additional hours we worked, but there's so many variables there that you can't just say it's this one thing. I think just the fact that our that we're keeping our FTEs. At least they've been stable around 100 for some time. We haven't seen a lot of growth in the FTEs.
And the nice thing is, on the FTEs, is we believe that we are staffed at a position where we can absorb the volume without adding a lot of staff.
We're locked and loaded. So, but part of that comes from that bottom bullet there, 9.7 contract FTEs. That we are much better off than a lot of facilities. The amount of registry and contract labor that other facilities deal with is astronomical. Ours is somewhat manageable, both.
Upwards of 25 to 30%.
Yeah.
In some places.
I think that's a testament to our managers and creating the environment people want to work in. Yeah, that's.
That's a big part.
Yeah, the nursing recruiting's been pretty robust. And the CNA program in long-term care, another one that is paying dividends, rewards, whatever the word is. And labs are probably our next big challenge. So it doesn't end. Does not end. We have, in addition to an aging population or an aging community, we have an aging workforce as well. So.
With fewer and fewer people going into healthcare.
Yeah.
Like a CLS, for instance, the one we're looking for now. I think scour the world for those. No one's becoming lab scientists. So, what's that?
So that's kind of a snapshot at our labor costs for the budget. Discussion or any questions?
I think you've explained it quite well, Steve.
Okay.
Thank you.
Thank you.
One thing I do want to run through, especially if we have Don on the phone still, hour and a half later. Can we go towards it's got to be, Sarah, I'm sorry. It's the last two slides. Oh, no, you know what? Sorry, this is everything. So it would be, let me give you a page. It was page 14, sorry. Is that the next page? Okay.
The last two slides.
Okay.
Up to the end.
Okay. So I'll just, I can. So here's kind of the summary, comparing to fiscal year ending 6/30/23. Our bottom line, net income. I'm confusing myself. Our bottom line income, it was a loss in 24. So our bottom line income is an improvement of 1,000,002, you can read it, 1,262,63, made up of a projection of 1.8 million in increase in net patient revenue and 281,000 increase in operating expense. There's a 526,000 decrease in true non-operating. The interest income went down. We're projecting that it will go down just around $60,000. At least from an accounting perspective, for fiscal 23, we received a $250,000 COVID CHIP grant, and we used some of that money on similar things that I identified that we used the provider relief funds. That was a one-time injection. And we're not budgeting for any new hospital bill donations. That's going to come out of our 23 operations. I've shown that as income. The auditors already said that needs to be put into a designated fund and not shown as income in the financial statements. Because we're going to use it to on capital
Does
expenditures.
that also include the bond measure revenue?
We will have none in there. We will have none in there, probably not through 24. We're not going to draw on the GO bonds. We'll have the COP money coming in, but the GO bonds is an in and out.
Okay.
Basically, we get a receipt of tax funds and we pay the debt service. And so it's a net zero, and the accountants probably want to show it gross. So it's a,
Is this floating out there still?
Sarah,
Sean.
do you see Rich trying to join the meeting? He says he's trying to get in.
Who is trying
Rich,
to admit?
I think
Go to admit. There we go. There we go.
is he in now?
He'll pop up here. in a
Okay.
second.
Perfect, thank you.
Yep, there he is.
Hey, Rich.
Still says connecting there.
I can't see it from here. Thank you. I'm going blind.
Is there anything for Donna while she's on?
There we go.
Anything for
So-
Donna that we need to talk
Well,
about?
during.
well, I'm going to go to the last one, but
Okay.
can you ask Rich if he's been trying to get on for a bit, and if you have any questions that didn't get answered?
Well,
or
we can
addressed?
ask him, we can ask him.
When he's on.
Rich, can you hear us now?
I'm on. I've been trying to get on for a little bit.
Sorry, we had the other screen up, so we didn't realize. Steve was wondering if you had any specific questions that you wanted to ask that we may or may not have covered already, but he wanted to make sure that you got your questions answered.
I don't know if you talked about cash flow at all.
We're just about to get there, so you showed up just at
Perfect
the right time.
Yeah. I'm sorry. I had to have some x-rays, and you know how we have to wait at a hospital to have things done. So
Darn hospitals.
Well, we're glad you joined us, Rich.
glad to be here. Go ahead. Sorry.
All right, so that's and then the last piece on slide 27 is that we are showing an increase in the net supplemental payments. And this, Shelley, is the, I don't know, the frenetic nature of some of these supplemental programs that we were supposed to receive our HQAF, it was calendar 22 or whatever it was, in fiscal 23. We're supposed to receive it in the spring, as we'll receive the others. We just did it this week. We just made the IGT for that this week, and we'll be receiving a supplemental payment. There's a quick turnaround. They're acknowledging they're late, so they've talked to the managed care plans and said, you guys got to turn this payment around fast, and they're getting the money to them. So we'll see that. So theoretically, we would see another HQAF payment in the spring of 24, but we haven't budgeted for that because there's just, we can't say that it is, and it's going to come eventually. So, I don't know what
We don't know when.
budgeting for it if we don't get it, what it is. So anyway, just again, conservative. We got one payment in there, and that's good. All right, Sarah, if we could just buzz to 28. Okay, just for a point of reference, this is kind of the way, this was the way we did the presentation of cash. So as of June 30, 2023, we had just over $11 million. What we were doing is we were putting the money into really three buckets. This designated capital reserve, it's where the board had approved spending capital money, but not specific capital purchases. We said we wanted to do these things, the money set, and we bring the specific contracts to the board for approval, and then we would expend the funds, and then we do a drawdown. I need to update that. That's a little high. But then we also had this designated operating reserve that kind of started before my time, where the board decided to essentially put away a rainy day fund kind of thing. And I've just been adding interest income to that over time. And so it grew to that amount. So we really had what we call undesignated. I don't want to call it restricted because it really isn't restricted. It's just kind of board designating, you know. There's not a donor restriction. There's not a restriction from a lender or anything like that. It's really the board has kind of directed this. This led to total day cash on hand that'd be off the 11 million. So, we kind of got to put all our money in one pot now. So let's talk about that for the time being, Jerry. So let's go to the next slide.
He saw my face.
No, I heard the Okay, so here's the way, with the way that we've done the budget. Here's the way that cash projects out. So we'll start with the $11 million. The net income cash flow, that's the 152, 153,000 and adding back depreciation, which is
Oh, okay.
a non-cash expenditure. We could go back to the slide if you want to see it. Actually, you know what? We can look at that. So new build expenditures. So what we have, Sarah, can we go to, oh boy, let me go to, let's go to about page 25. Let's see where that leaves us. Why don't you go up one and see where what the last page was on that one?
Well, she might have to go, yeah, there you go.
Yeah, keep going up about, go to page 20, or just. Yeah, 2 more, 18. Yeah, so,
There we go.
okay. So can you shrink this down so we can possibly see the whole thing? That's good.
Or see that in it.
That is.
So,
Keep going.
yeah, arrow down so we can get the, where's that? So down, of course, I'm gonna say arrow up. Just see if we can get one more click out of it, one more enlargement out of it. Okay, now just arrow down just a tiny bit. No, that's good, that's got everything. Okay, so here's the projected cash flow for the budget, and we are on page 18, document 2 of 8. So we start with our net income of the 152,000. Then we add in depreciation, again, a non-cash expenditure. And then the subtractions from cash flow, the first one is principal payments on long-term debt. That's solely our lease on the CT, which actually will be completely paid off in calendar 24 after June 30th. So that's great news. We had 2 payments relating to cost reports, 223,000. I'm estimating decreases in current liabilities from amounts that were outstanding at the end of June 30. Then the new hospital build expenditures through September 30. Do I want to say that right? Yeah, through September 30, the direct payments we made are $982,048. Then this new build equity contribution. So right now, we're talking with the USDA, and in our loan application to them, we said that we will put up $8 million for our owner's equity, our portion of the project. So 8 million on the 70 whatever million dollars. What they're saying to us, what they said in the letter of conditions, is that they want us to put up the $8 million and have that money be $1. All expenditures will come out of that $8 million first. So after they picked me up off the ground, stood me up, our underwriter said, okay, we've seen this before. Tell us how much you've spent already. And so it's about $4.2 million when you consider the 982,000 in there. So what we're gonna say to USDA is we're gonna take the 4.2 we've spent, and then we're gonna add the 3.8, whatever gets us to the number. And then we're gonna have our owner's contribution met. And therefore, when we move forward, when we get our funding, from day one, it's coming right out of the loan proceeds, and we're out as far as making a financial contribution.
And I was unclear if
Backfill.
this is just, we're coming back to them with this proposal, or this has been agreed upon, was he there,
The first one,
the first one?
because
We've already spent 4 into the 8.
quite frankly, it was incredibly unclear. And I'm sure you had your concerns with the letter of condition, and rightfully so. So we have to talk through this, but our experience with them has been that, the USDA that is that they come up with these positions, and then when we can demonstrate, look, this is how it's been done before, why are you doing this to us? Where's your grounds? And specifically, the underwriter was a critical access project they did in Washington State. So I think
There's precedent.
there's precedent. You want to be our partner. When they sent the letter of conditions and the documents, they said they're looking forward to being our partner in this project.
So let's be a partner.
So when are we gonna know if they agree with us?
We're sending it out this week.
Okay.
So we will know quickly. We have other issues to sort through with them because their letter of conditions was a voluminous. So, anyway, so that's the approach we're taking there. The other way, if it works, if they say, okay, no, you gotta put up the 8 million, then we want our money back. We want the money we spent today, just work with us, please.
And per the USDA loan proposal, we had to have, was it 100 days cash on hand?
We had to have 80.
80, okay.
We had to have 80.
Okay.
So,
But that's later on, once we actually have our permanent
yeah,
financing.
once we get to
And we're
the,
paying on that loan every year.
once we get to the closing. So one of the things that I wanted to talk about this is that this 5.9 million there at the bottom is our projected cash balance at the end of June 30, 24. There's gonna be a bit of a ride to get there. We're still having struggles with getting our payments within the normal revenue cycle through Cerner and AmeriCare being our long-term care billing for long-term care, I should say. And so we're gonna experience, when we look at our financials, when you get them, when you look at the financials for October, you're gonna see a drop in our cash. So we're just gonna have to work through that to where we get to, when we have to write that $3.88 million check, it will deplete our money below 100 days. We're gonna be probably one of our lowest levels since I've been here. The other piece of that is that this supplemental money, which the QIP may come in a little earlier, Shelley, but this net supplemental payment that's gonna be 5.2, over $3 million is going to come in the spring of 2024. So it's just going to be a different ride for us, especially Jerry and Ken and Rich, to where we, have always had flush reserves. So it's just it's something different. And that's, Jerry, why I'm saying for some period of time, we can set aside that $3.8 million right away and say, boom, that's it. And here's our money we're dealing with. But other than that, we're more or less set aside the hospital donations of just over $300,000 to date. So it's just going to look different. And
Yeah, and when
don't think that it doesn't bother me.
So we
it
do have a
should.
reimbursement. We did have the resolution for reimbursement. The question is that come from the COP or is that going to come from the band?
Well, the way that the USDA is pushing us, we'll never ask for money from them. And if we get this solution, we'll meet our equity contribution when we close the funding here in December, early January.
Which means that we can start to reimburse ourselves for that.
Well, the way that we're interpreting it is that we're done. We're done.
So now we just build back our cash reserve.
We put in our $8 million, and now every project payment will be made out of COPs and in turn the GO bonds. That's the way it's playing out right now.
So when you're talking 8 million, what we're looking at on this is 5.
Which 5?
The new hospital build expenditures and the new build equity contribution.
Yeah, 4.8.
I'm rounding.
That's fine. That's
But-
fine. Just because there's other 5s bouncing around there. I just want to make sure.
Yeah. But you were just saying 8, so
8 what?
million.
Oh,
Yeah, because we're already in for almost 4 million.
Okay, so this, okay, I got you.
this is what
Thank
it's
you.
what we need to contribute.
Yeah.
It's interesting math.
So, when we met with the finance committee, we went over kind of a timeline for when cash was gonna go and come in and out, and I know,
What was that?
I think we lost him.
Yeah. Okay, it's not me.
No, not you.
I had audio going out a few times. Did you too, Donna?
Just one other time I noticed it. I wonder if they can hear us.
I had a low battery message appear on my screen.
Oh, I wonder if that's it.
Did I text Jerry?
Yeah, you want me to do it or you want to?
Oh, I got a text from her.
Oh, okay.
Says battery died. We'll get back on shortly.
Okay, sounds good. We'll sit tight, huh?
Where are you? In Sacramento?
Yeah, Sacramento.
I'm in Southern California. I had to have a little medical test done today, so.
Oh, okay, okay. Are you heading back up anytime soon?
Well, I was planning to go to Washington, but since we don't have a House Speaker, there's no committee meetings. So all that, my whole schedule was canceled because of what's going on in DC right now.
Yeah, okay, okay.
But health equity is becoming such a big issue. I don't know if you're aware of it. I know that Sutter is aware of it because a good friend of mine had to respond to the state of California and come up with all the apps that are biased for patients.
Oh, really?
Yeah, including, I think he came up with 60. He was the chief digital officer at Sutter. Sutter has had major changes, you may know, when they brought in all the Oxner, the new CEO.
Yeah. After Sarah.
He's bringing in his whole staff. from New Orleans
Oh,
and replacing all the people
Dropping down.
that have been there for years. Oh, we're back on.
But it seems like there's a way around it either.
Rich, can you hear us?
Yes, yes.
Okay, sorry.
Okay, pay your bills. Yeah.
So yeah, so we had, during the finance committee, we had looked at kind of an initial draft of a timeline for when cash is coming in and out related to this. And I know we need to delve into that in more detail to really kind of flesh it out to finalize, but maybe give kind of an overview for board members, because I don't think that's in here, right?
It's not.
So it seemed a little bit aggressive to me in terms of timing, but
Yeah, so there's a combination of things that are going on there. Is that in addition to this document here, which gets us to the initial funding of the interim financing through the certificates of participation, which would take place per Piper Sandler's estimate by the end of the year, the first January of 2024. So between now and then, there's some commitments we have towards the project, and we will need to make payments on that. So it's a matter of determining how much we have to do, the payments we need to make. But what this will do is, so let me just do simple numbers here. That our equity commitment is $8,060,000. We are in for whatever the difference is there, $4,180,000. So that's where we're in as of September 30. So if we make additional payments between now and December, then that just reduces our amount to do the equity contribution. The only thing that we'll have to be very, very clear on is part of what we truly own as equity contribution is the funded interest for the COP bonds. So in other words, there's going to be a debt service on those bonds. Basically, it's going to be interest only. So it's $4 million or whatever the number is. That our underwriters say that they feel that that's something that's going to be asked, because it's commonly done that way, that we pre-fund that amount upon closing. Now, they've told us that there may be ways to do this where we fund that quarterly, we fund that semi-annually, we fund that on whatever basis. So that would be the only real curveball for us, is if we go along and we pay down our owner's equity commitment through project expenditures, we most likely would not have the full amount to, I shouldn't say that. It'll be close. It'll leave us with less reserves than we really want to. So can we structure it so that we don't have to do it? Or if we pay these down, will they then give us credit for that we've met our owner's equity? And in essence, we could bring the funded interest back up with a reimbursement draw, or however that works. Those are the mechanisms we need to work out.
What a lot of moving parts here.
Man,
It is. Steve's done a great job of keeping me on track.
And when we talk about paying ourselves back, help me understand that a little more, because if we have a certain amount that's our contribution that we are required to put up and we meet that, then how would we be paying ourselves back any of that? Because that is what we were required to put up in the first place.
only if we exceed our owner's contribution, because we have to make project payments and we have to fully fund the interest.
Okay.
But that money, per the underwriters, hits our bank upon closing.
So we would have the funds set aside
Funds
for
immediately.
build, that we can then be drawing
Then
down on
year-
that
and then
instead of our
years to build back
operating.
cash reserves,
Yes.
And the ink on the resolution reimbursing us wouldn't even be dry, but
You know, we're gonna,
You
the second
mean you
it's there, we're
already have
gonna
it
pull it.
printed?
got the deposit slip filled out.
Yeah, there you go.
I don't know. That's
Okay.
the mechanisms we're going through. It's just,
Wow, you're right. Couldn't be more complicated.
Mhm.
It's very complicated and, you know, just trying to balance out the financial health of the organization, and timing is a big thing.
Yeah,
Big
timing is everything.
issues.
Steve, I'm curious about, what your sense is related to, I guess our bottom line for cash on hand, days cash on hand.
you have to pick a point in time. You mean when this thing goes,
He wants to know the worst case, the worst month this
Yeah.
upcoming fiscal year, because that's
That's
on
really
my
where I'm
mind
going.
You
too.
mentioned the lowest of the low.
well, I
I
think,
think something we don't want to do, I guess.
Well-
Like 10 days.
Mm-mm,
No.
mm-mm.
You said under less than 100, less than 80? Or less
oh
than-
yeah, oh yeah. But it'll, okay, let me back up. At Thursday's board meeting, materials will be going out. We could have an expanded discussion about that we still don't have financials. I'm still presenting the same information. But we will have a really hard look at our revenue cycle, because what we're seeing now is that we are collecting, I don't know, let's call it 75% of our normal collections. And that's just on the hospital and clinic. We still have not been able to, Sarah Lynn said she had checks on her desk from California Health and Wellness, so I was not able to confirm whether or not we've received a payment under AmeriCare. We began billing for long-term care through AmeriCare on June 1. During that time, we dealt with a myriad of issues, from getting patients authorized because they moved from straight Medi-Cal to, you've heard the story. And then when we submitted claims, California Health and Wellness actually bills long-term care or requested claims be sent in differently than Medi-Cal, which to me, everyone was saying, how can that be? It shouldn't it follow Medi-Cal rules? It doesn't. So there's been immense struggles. I think we're there, but we're sitting on essentially $1 million of collectible AR and long-term care through September. And we're a week and a half away from submitting claims for October. So that's an incredible obstruction to our cash flow. And that will come swooping in when it does. The 25% off the hospital side is probably the equivalent of, a couple $100,000 a month. So again, that's June 1. So we're maybe out another $1 million. So we've got approximately $2 million of AR sitting there that should be collectible.
Is the issue with AmeriCare then? Is that what you're saying?
I've been so incredibly impressed with AmeriCare and the way that they worked with us. They're everything Cerner wasn't. And I don't care what Cerner thinks of that comment, but they are, and they worked with us, but they were scratching their heads. They're just looking at Medi-Cal,
That makes sense.
and they had not dealt with certainly California Health and Wellness. Now, California Health and Wellness, gave us their book and everything, and we said, yeah, it says this and says that. Biggest problem with them is one of one of the things that they negotiated apparently with the state was that our contract with California Health and Wellness says they'll adjudicate claims within 30 days. Well, they basically just got an okie dokie or something from Medi-Cal that they can now push that out to 45 days. And so the problem is that if we call on the claims, what they'll tell us is, they'll tell us it's in processing. So in many cases, we wait the 45 days, it denies. That's what we've experienced. So it's been, to give them credit, California Health and Wellness has worked with us. They've given us direct access to them, but still, even with their assistance and saying we'll prioritize batches, we haven't had success. Now, what we had success with is we're starting to get payments from the Evident system. So in addition to going live with Cerner on June 1, we still had existing issues in Evident because we were experiencing the same things, that we were billing the claims not to their specifications. I don't even want to say wrong, but not to their specifications, and we went around and around. So we finally got traction on that, which means that we now believe that that we will be moving forward. The other problem is that what was an AmeriCare issue is the way that the claims came out of AmeriCare and went through our clearinghouse SSI, because they were editing it, because they didn't recognize some of the things that we had in there. So we can talk through that. Our ones made a nice presentation for September with a lot of good information. But so that's a roundabout way of saying that those funds could cover some of our cringe of getting through the meeting the owner's equity. So
collecting AR, volume shifting, getting the volume back up so that our ops, we're not pulling from our cash reserves in operations. That's
I
really,
think my
those
question
things
really
have to
goes
come
to, as a board member, at what point should I be getting
Uncomfortable.
sweating bullets?
about a year and a half ago, we started this whole process.
Yeah, I'm just, days of cash on hand, anything below 80, anything below. Put you on the spot. I'm sorry.
no.
Space says it all.
I think the biggest thing for days cash on hand is, well, there's a couple things with Seneca. With Seneca, we operate at a loss for essentially 9 months of the year because because of the timing of the supplemental payments. Then all the money comes whooshing in, and we're, if you look at our days cash on hand on a historical basis, it drops and then it goes up. So what days cash on hand does for us is it helps us weather those downturns.
Yeah, I understand it's a moving target.
Well, it's a
what's
little more than that.
floating out there.
Because we've never had to make financial commitments like we are doing now.
Right.
And that's what's brought our numbers. So here's what I can do. Let me put together some projections about cash flow over the next 12 months. I think that's, it'd be good for all of us. So
using AR days of what?
Well,
because if we deal with a big AR, then hit the AR again, then it gets extreme.
I don't anticipate anything pushing AR much higher. Problem is that we're now getting flat. We're just staying at this level. And so I don't see that we're in a situation where, there's no cash coming in, that kind of thing. That's not us at all.
So
Wow.
new claims are being paid. It's the old claims that we're still having, that we're trying to resolve then.
Commercial denials.
I think the biggest thing, here's two things we're seeing, and I don't mind talking about this at all. Here it's as opposed to Thursday, is our discharge not final bill is huge. It's 20 days. Our target is less than 10. So on average daily revenue of, let's just say 60,000 on round numbers, that we're talking upwards to $1 million of AR that's just sitting in there not being billed, and it's for a variety of reasons.
What are the reasons? What are the
Uh,
reasons?
There's, so we have what's called workflow issues, Rich, which means that things get to coding and they're unable to code claims in order to get them out the door. So they have to do manual intervention. Sometimes they're sent back to the department. Sometimes they're sent to the physician, whoever it might be that has to do it. The involvement of the coder in this then creates an additional backlog with legitimate claims that are complete.
Pete, I get all that. Well, why are we having this problem with our new product, with Cerner and our new billing system?
I had a conversation this morning with Shell, first thing this morning, to talk about where the rough spots are and to define them more carefully so that we can have a pointed education, pointed retraining. A lot of them are around, and you may not understand this, but a lot of them are around physicians establishing problems lists when patients come in. So when they establish the problems list, which is the first thing that they do, okay, they're not doing it. So there's nothing that's coming out with the diagnosis code. So everything that they do it has to be coded properly. The biggest thing for retraining is getting our ER physicians to do their problems list, period.
Yeah, and that was a big problem for us too, Rich, at North Bay when we transitioned to Cerner.
And how did you
Big
solve it?
training.
How did you solve it?
Training.
A lot of training, a lot of education with the physicians.
So this is still an ongoing problem.
It is for some of our local
Downstream.
doctors. We have two or three ER doctors that are very good. The rest of them just don't seem to understand that problems list is the key to the castle.
Okay.
It's the keys to the castle.
Coding.
And then in the clinic, there's really very few issues. There's a few that we want to deal with around signing orders and signing those types of things. But as far as diagnosis codes, where there has to be required the coder to take care of it, it's lower in the clinic. We really have to focus our attention on our ER, all of them. And it's getting to the point that if they don't start doing this work, I'm going to stop paying the locum bills. I'll just stop paying them. I'll stop paying the local providers. It's just ridiculous.
Yeah.
They've been trained and trained and trained. This is what you do first, and then everything flows downstream from there. So we're going to be, Rich, to answer your question, there needs to be a huge focus on the first 3 steps of access into Cerner as a clinician, as a provider. And that just has to happen because like Steve said, now you've got these huge delays and the coder having to do it.
Mm-hmm.
So we can't have that. Steve, do you want to say anything about that?
Yeah, I do.
Okay.
So Rich, the short answer is Cerner is horrible in revenue cycle, and I'll go to the man on that one. Second thing is that they flat out told us, they said the best way, they fought us and fought us and fought us in the bill, and they said the best way to make this thing work is just go live and fix it in a go live environment. And boy, that was
Great methodology.
and so that's what we've done. So a couple things that we're looking at, Rich, is one is it takes money to make money, and we're looking at a proposal from R1 to come in and relieve the coding backlog. And what we're looking at there is there's stuff that can be coded right now and sent out. So anything, and this, we're also looking at this, Rich, and we obviously are gonna bring this to the board because this is a pretty significant arrangement for us. Not necessarily money-wise, but in our business model, is that we're looking to set up a mechanism where if a claim is uncoded after 5 days, it automatically goes into a bucket and will be coded by outside coding staff. And I think this is a fabulous thing to have, not only for us right now to get our backlog done, but when it creates a depth of coverage within our coding department that we currently don't have. So,
Okay,
Sean,
but you're solving it from the back end. The training part
yeah,
needs to
Yes.
be dealt with up front. That's the most important part.
and what
We
I agree,
talked
Rich.
about the possibility of having nursing support in that. I remember I mentioned it and it was rejected. So this is serious stuff.
I couldn't agree with you more. And so the other thing we're looking at is that problem is it's very hard to even sort through what we're doing just because of the volume of it. So if we can clear up the backlog, I've also put out a request for someone with Cerner optimization experience to come in and look at our workflows, look at our claim condition, and help us with that. That might not be what we want to do, but that certainly will be a focus. But until we get the inventory, the sheer inventory of accounts that are just sitting there with coding because it's the end of the road, it's going to be incredibly difficult for us to manage this.
Two-pronged approach, clear the backlog and train the ER physicians to start doing the workflow appropriately. They've all been trained. I don't know if it's an issue of I forgot or an issue of I'm not gonna do this, lack of compliance.
That's why you have super users close by.
It has super
So-
users.
We do, Rich, we do have one ER nurse who worked with Cerner at another facility. And she is basically what we're considering one of our nursing super users at the elbow with our ER physicians right now. So she's doing the best she can. I don't know how much she's working with them on their problem list, but I'll circle back with her. But she's basically taken that on and she's really enjoying it. But I'll follow up on that. Hopefully I can give you an update on Thursday.
Thank you.
Yeah, can you run a report for her to go back and work with the physicians and,
We
you
do have a
know?
report for which
You know?
physicians are delinquent, which
Yeah,
ones aren't working. I got that this morning. So we know who to focus on.
yeah.
Yeah, and our limitations there are just that she only works 3 days a week,
Oh,
you know?
Right.
And so it's gonna be kind of hit and miss until, you know.
Right.
Would it be possible for her to work maybe with another of the staff to kind of bring them up to the same level? So that way we have dual coverage potentially.
How many accounts are we talking about that are in the backlog? That are opportunities for AR?
So the backlog.
Well, you said it's about 1 million,
Hundreds.
right?
Hundreds.
Yeah,
But we've got to stop, we've got to stop feeding the bucket.
right.
Right.
We got to clean the bucket,
Mhm.
we got to stop feeding the bucket. So it's a two-pronged approach. Clean it back, clean up the bucket and stop or train our physicians to not continually fill that bucket, those coding buckets. And that's a matter of, I don't think it's not lack of training. We've trained them. They know how to do this. It's just they don't. It's just, I don't know, Sarah, what's the issue? I don't want to do this problems list.
So sporadically. that it's-
Yeah, that's the
That is a
problem.
hit and miss, yeah.
It's the in and out,
Not
in and
doing it
out,
all the time.
in and out.
Mhm.
And that's the other thing is stabilization of that emergency room. Fewer locums.
Can you do a hard stop? I think we talked about this before. You can't do a hard stop before they sign off on the,
Well, there's one hard stop I do want
The
to put in
chart.
there, and that is I found out when they're ordering radiology orders, which I said from the very beginning on this bill was going to be an issue. They can put it in and they don't have to put any diagnosis code in there, or any kind of diagnosis. It doesn't pull from the problems list, and it's not a hard stop.
Yeah, they
So
can put anything.
anything in there. That's why the workflow up front is that they put their problems lists in, and it can be 10 of them.
right.
They got to take the time to do that.
Yeah, it couldn't be more clear for them. There's red dots.
It's red dots all in
Everything
it.
that they're supposed to get done.
I would like to put a halt feature that you can't move on with anything until the problem with the problems list is it comes in with a problem. When they're admitted, that's the initial problems
Right.
list. And what they've got to do is add on to that,
Mhm.
right? As they examine the patient,
Mhm.
that can add their problems list.
Mhm.
Gosh, we definitely gotta get a hold of this because I know the bucket's filling and Steve's trying to clean the bucket.
Yeah,
As long as the water's still flowing in that
a
bucket.
lot of
we're gonna be behind.
opportunity there for money.
Well, and that seems like maybe a QA issue as well, because
It is a
if you're
QA.
not tracking what the patient's problem is, then you're not tracking what the patient's problem is. And I think that's definitely something
Yeah,
that should go
yeah,
to QA.
CDI, documentation is just a fight that everyone fights for their entire lives. You know, ever since the electronic health record came out, physicians are not secretaries, and they'll tell you that.
Yeah, well.
Not my job.
It
If
means
we're not able
money.
to bill $1 million,
huge.
then
That's
that's a
why-
huge problem.
That's why, my approach is train, give them all the training in the world, and then say, well, if you can't do this, I'm sorry, I can't pay because we can't collect.
So do we have a CDI department here?
No, gosh,
Oh, silly question.
Wish we
We
did.
have care coordination that's constantly monitoring
I know.
if the physicians have checked Interpol prior to admission, that sort of thing, but, that's.
That's it.
But the physician, it still is the physician's work responsibility to do that. So they can run over and say, this diagnosis won't work, this won't help us qualify this
Right.
admission. That,
Mhm.
no, we don't have a CDI department.
Mm. Do we have a lot of denials for inappropriate admissions?
Yeah.
We do.
Yeah, not documenting appropriately for people to make a decision.
Mhm.
So then we have to fight it. And then we could probably fight the insurance companies if there's proper documentation about what they were thinking
Right,
when they admitted. Even if they didn't meet qualifications, if they could justify it through their
Right.
documentation, it's fairly easy to go to the insurance company and go, well, here's what the doctor was thinking. Yeah, Interqual said no,
right.
but there were other circumstances that are documented here that says this is appropriate action. It's all a matter of documentation, So
Mhm,
what am I thinking and what did I do?
mhm.
And we unfortunately,
Well, being so small, that's a huge challenge for us.
So with that, I guess I'll go ahead.
I'm sorry to beat this to death, but when we're considering, lost revenue opportunities, considering the denials, what percentage of that 75% or I guess it's 25% equates to denials, inappropriate admissions?
I'd want to break that one up, Shelley, between denials and inappropriate admissions. Inappropriate admissions are really a smaller piece of our business. So it's the outpatient is really the bulk of our business, maybe a little bit of observation.
Okay.
But it's right now, our denials, I think our denials have been less of an issue so far. It's getting them to even get denied is the challenge. It's our stuff that's sitting and not billed. And that's
Then
what,
it gets even worse if they are denied.
well, it's kind of like the California Health and Wellness. We wait 45 days to see it's not denied, but
can I ask you a question on the not billed?
Yep.
Just from a workflow perspective, is that because physicians are not signing off?
I Rich didn't get to see me shrugging my shoulders, so, but I don't want to do that. I'm just saying that there is a myriad of issues that's preventing that. I'll give you another example of how fun my life's been lately, is that, so in April of this year, CMS decides that they're gonna go back and they're gonna start looking all the way that they credential specialty providers. And what gets caught up in this snare is physical therapy. And so all of a sudden, from April 1 forward, we have to re-credential our physical therapist. And it's taken
Crazy.
this much
There
time.
there was no forewarning at all, nothing.
It just, the shoe dropped. Maybe they hit it in some, bulletin or whatever, but it just happened. And
But
so,
only physical therapy.
for Medicare, which is maybe $50,000 a month, $40,000 a month of our revenue that's just sitting there. That's another one that's sitting in not billed because Medicare will deny it because they don't recognize him. So that's completely unrelated to Cerner, but just some of the other things that we're dealing with. I think what we're seeing now is that when we show you the report from R1, we're starting to see some of the denials now that are starting to come in a little more because we're releasing more things out of sounds like a contradiction. Our unbilled building, but we're releasing more. But no, we really are releasing more claims out there. And so they are hitting actual payer edits. And the examples are additional, and I know you say, well, what's in there? That's what I said. Additional info needed, billing submission errors, coding modifiers, duplicate claims. This is an issue with the way that the codes are being seen. They're seeing the codes and they're considering it a duplicate claim. So it's just the stuff we have to work with. But the biggest thing is we can live with this, we can manage this, but we need to send everything out. So
Steve, if we engage with R1 to help with the backlog, how quickly do they think they could actually go through it?
they haven't given us like here's your inventory, here's how long it's gonna take us.
Okay.
But they have coders, so it shouldn't, if you left Shell Stoops alone and turned her loose on those, she'd have them done in a few days. So,
So they don't have to reach out to the physicians at all? The R1 team?
Shell is saying there's an inventory of accounts that she just can't get to. That's just sitting there because she's working on the problem children.
So I'm a little confused about the process, or just like a little more clarity on it. The coder is working from the doctor's notes. What are they working from?
Well, they're working from the whole chart, yes, but what happens is, the way that Cerner works is they have this thing called a work queue. And when something comes up, it is assigned to a particular work queue, and one is coding. And coding has a whole myriad of issues that are in there. And there'll be a slide in there that they show what they call client assistance, things that have come back from R1 that have been assigned to a work queue. And for the most part, the bulk of the things go into Shell's work queue
And then they're prioritized how?
by Shell.
That's not a way of generating business for R1, is it?
What's that?
R1 kicking things into a work queue and going, I'm gonna bury a coder, buy some coding from us.
I guess we'll find out, but I think that they would probably want the money faster by just sending out billable clean claims that they get money on, not having to.
What percentage do they get?
Well, we have a very nice arrangement with them. It's a little over 3%. So that's a good rate. And I think they said something about, I can't remember what they said. They have a flat rate for coding charts.
My philosophy is always going, go to where the glacier melts. That's just my philosophy. And I agree, Rich, train the trainers, continuous training. And then once the training's been put in place, then it's either a compliance issue or a laziness issue. And that's just the way it is. And I hate to sound so jaded, but I've played this game before so many times that we can throw all the training you want at it, but it becomes a compliance or a laziness issue. And laziness is and I don't know how the board feels about this, but if you cannot do this properly, I'm sorry, it's part of the charting, it's in your contract, right? I will not pay you because it's about money. It's the pocketbook is what generates activity.
I don't know if you can not pay them, but you can certainly take them off the schedule.
I cannot pay the locum company.
Oh, the
Say,
company, oh.
I won't pay the locum company. Now you want it. Now you've got to pressure this person to start adopting this electronic health record because I just won't pay you. And you can have that conversation with the doctor that I've had 20 times.
Mm-hmm.
So it's, you got to put pressure on and pressure off. And it's a never ending thing. Stabilization in the ER would be fantastic because it can really focus on less of a round robin, less of a revolving door with locums in there. I've talked about a group or forming a group, stuff like that. So we have stability instead of these locums. I don't want to use locums. I'd rather have somebody have buy-in.
Right, yeah, and if they're coming in one or two shifts a month, then it'd be hard for them maybe to remember what to do in our system versus someone else's
Mhm.
system.
Mhm.
So, yeah, okay.
Okay, well, we definitely have to get at this because it will affect our flow.
Yeah, and we've done so much work so far. I had a conversation with R1 this morning, and they have a progression on the way that they do transitions during system implementations. We had the team on the build side, then we went to what's called this ops, which is the short term. When you first start going into a live environment, they have a team that works with you, and they're still very much focused on trying to troubleshoot the system and making sure that before Cerner moves off of their support, which they finally have moved for patient accounting revenue cycle. They've moved off of the build team. We're now into the AMS term you've heard. We're into the general support. So what we want to do during this ops time is to make sure that we get in any service requests, the SRs, to fix the system. A lot of it is the rules they write. And that's a thing about Cerner, is that they write these damn rules in there, and they love to say why it's not firing or why it's firing wrong. I mean, Cerner, I think a big thing with Cerner is that especially with a small hospital like us, we're so used to taking what the system gives us and then making it work to get a damn bill out. Cerner, which is great, it's a great concept. Build it right and all that stuff goes away and claims fly out. But if you don't build it right, man, oh man, you're chasing your tail on a lot of stuff. So we go from this ops to what's called long-term, and that's the ongoing regular team. So what I've asked R1 directly is, I said, before we go with the long-term group, we want to meet with them, their leadership, and we want to meet with the big boss too, the person that's over the whole thing, who we met during the sales pitch time. And we want to say, here's where we think we're at. Here's what we think we need to be done. Here's what we've done. And we want the focus of the long-term care team to be on these specific things. Because I think that when we went to the ops, we just kind of let it flow in, and we didn't dictate how it was going to be undertaken. And now we're just going to say, fine, you do your business, but we want to all be in agreement what the damn problem is here, and we want to figure out how to fix it and how to move forward. So that's a different conversation we're going to have with them, and I think that's going to help, because we are really close. We put in so much work, everybody. And it's a shame that we're still struggling. It really is. So, but struggling less than others, let's be glass half full here.
It will be positive 6 to 9 months, or 9 to 12 months to completely stabilize a new electronic health record generally. We're 6 months in, we've made a lot of progress, but that's on average 9 to 12 months to really make it.
So if we bring in this R1 to help us with this problems list and the coding issues, how will that help us with the money that we need?
Well,
Claim push through.
2 ways, yeah. So one, what they're going to do actually is they're going to work on the stuff that's ready to go, that we know is good, and they're just going to code it and send it out and just accelerate cash flow.
Mhm.
What I believe we can do is then Shell Stoops can isolate or focus, like I said, when I said problem children, not problem children people, problem children accounts. And then we can isolate the issues and then root cause it, blah, 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 CQI and all that. That's the way revenue cycles should work. So, but we're just so overwhelmed with everything. And if Shell doesn't have to worry about getting the clean stuff out, and that somebody can just do that and keep her backlog then I think
So it could help our cash on hand.
it has to. It'll get the billing, two things will happen. In the short term, it'll accelerate cash because those claims will go out.
Mhm.
We'll start fixing more accounts, and then ultimately we'll root cause things, and we'll have permanent fixes in place, whether it's people or process or system.
So when would we anticipate having a proposal?
This week,
So would we want to have a special to review it and approve it before our next meeting? So next meeting is not for,
I think that'd be a Jim Daniel idea, and also I think that we would want to look at doing at that meeting is breaking down the cash flow a little more,
Okay.
or a lot more,
a lot more.
month by month components. So, instead of just throwing a $3.9 million number at you, show you exactly what
Yeah.
is constituted, plus we'll have a little more feedback from the USDA and others on how this could work.
Okay.
That'd be great.
So will your nurse who's helping with this backlog and this problem list, training, can she be part of the RCA? I think that's critical.
I will chat with her and see.
Yeah.
Right now, she's only, it's when she's on duty on shift. She's not coming in extra to do anything right now, so. But
Okay.
I would need to know more information on the offenders to see
Yeah.
how that might look.
Work with R1 and all of that.
Yeah, because we're
Doug
fairly,
Nielsen does a really good job of trying to onboard these guys and his problem lists are spotless. He does such a great job. It's none of his charts that we're dealing with, I'm sure. But I don't know why it just doesn't stick.
and Mark's also been a champion in the interqual.
Okay. Good.
Yeah, medical necessity, big time. That's where it all comes from, is the ER, so, okay.
So just maybe let me know approximately when you think that I ought to set the special for, and then I'll have Deborah poll board members for availability. Any other questions, comments about the operating budget? Rich, do you have anything else?
Yes, I have one question about cash flow.
Okay.
And it relates to donations. What
Okay.
is our timeline and how could we accelerate it?
I think that's a question for Sean.
For donations.
Yeah, I think he wants to know when we're gonna accelerate our philanthropic request, outreach, thank you.
Yeah. Program.
We have time. We have getting the artifacts in place, are really important. We don't have that yet still. So I can go to the community. We need to have a plan. I'd like to have a subcommittee actually from the board to talk about philanthropy.
Okay.
And the attack, how we go about doing it from a logistics perspective. I mean, I can put together funding circles. We already have several that want to do that, have the right artifacts give, things to that effect. I am going to be bringing up to the board. It's on the agenda, I believe, resurrecting the discussion on foundation work. So
What do you mean artifacts?
artifacts, things to pass out to people, things that define what we're looking
Like the
for.
flu, during the flu clinic.
What was that?
I think during the flu clinic, the drive-through, you mentioned having a flyer.
Yeah,
With,
I don't know
with-
if that's what we're talking about right here.
It's multiple things. It's pamphlets, it's full pamphlets, it's mailers, it's all these types of things. I guess, is the question, are we gonna hit the giving season this year?
And it's probably where he was going with that,
Probably not.
I guess.
Yes.
Well, no. I mean, the giving season starts in June, so we are collecting donations. They've been flowing in. I would say that we're behind on that entire campaign.
So it sounds to me that maybe on Thursday, when you're giving your report, we can decide which board members want to be part of this committee to assist with that work. Does that sound reasonable?
If a subcommittee is something that the board thinks would be helpful, I think it would. It's just myself and Chelsea at this point,
Mhm.
you know, pulling this together. I think it'd be helpful to have board members that are on this committee to start targeting
Yeah.
the effort
Agreed.
instead of just shotgunning it, start targeting it, you know, and it's actually, and the target's gonna be multiple targets. It's multiple, it's large givers, it's endowment givers, it's those types of community outreach, it's, you know, foundational outreach, those types of things.
Yeah, and I would expect that,
Need a little help here.
yeah,
You know, I'm
board-
trying to transition, as you know, into that, more of that role, right?
Right.
Because we've been so steeped in operations. And that's not an excuse, guys, but we've been steeped in operations for a long time. It's trying to get up and out of that and get that thing going and the funding, so.
Is this something the COO will help us
Yes,
too?
the COO is getting, yes, the COO will be taking over a great deal of the operational, day-to-day operations, tactical, block and tackle type stuff, where it frees up, you know, the CEO's position really is to be out all the time and generating money and generating these types of things and communication and strategies and things to that effect. So yes, the answer is yes.
So I think so, board members, if you want to, you know, think about that, and then on Thursday, we'll discuss who wants to really help drive the philanthropic giving for our new build, because I think that is very important, and I think we should be more engaged in assisting with that.
And I'm gonna tell you, I will be shifting a great deal of my focus toward that. But yes, we're behind Rich.
I guess we'll talk about the COO.
On Thursday, I think, yeah. Any other questions, comments around the budget, cash flows? No? Thank you for going through that in such detail. We really appreciate it.
Thank you.
Yes,
very much.
we really do.
Yeah, it was nicely done. Thank you.
Thanks, Steve.
Okay.
So I will accept a motion to approve the fiscal year ending 6/30/24 operating budget.
I'll make the motion to approve.
Thank
I'll
you.
second.
Thank you. All in favor, Rich,
Aye.
Shelley,
Aye.
Sherry,
Aye.
Ken,
All right,
and I'll vote aye. Thank you.
get a little more insight every time we do this.
Likewise. One comment, I need to thank Judy Klein and Kristen Rutowski for their work on the budget. I wouldn't have got it completed without their assistance, so
Yes,
that was very, very helpful this year.
please convey that to Kristen as well. Yeah. Okay, so next we have our authorized signers. SHG long-term activity bank account changed authorized signers for the long-term activity bank account. Do you have any questions or comments around this? We're just updating based on current staffing.
Oh,
That's
okay.
what that's for.
Okay.
No questions, and I'll accept a motion to approve the change.
Move approval.
Thank you, Sherry. Do I have a second?
Second.
Thanks, Ken. All in favor, Ken?
Aye.
Sherry?
Aye.
Shelley?
Aye.
Rich?
Aye.
And I'll vote aye. Thank you. Okay, we don't have any information-only agenda items, so we shall adjourn to closed session. Do you guys need a break, or
So when we use text, you want to go back and
we'll take 5 minutes, Rich.
okay. We'll do it.
If you can still hear me. You can start recording.